Hello, and welcome back to the Scientific Ethics Lecture, where we continue on our discussion of looking at what we can learn from the genetic information, looking at how we can use that DNA code, how we can use the information that's kind of in that sequence of DNA, the A's, the T's, the G's, and the C's. How can we use that to, kind of better understand an individual, better understand kind of their risk factors, and potentially how can we use that information to improve their medical treatment? And so today what we're going to look at is genetic information and personalized medicine. Now, the idea of personalized medicine is that it's going to focus in on the individual themselves. They're going to focus in on a very precise way of treating that patient. And so if we take a look at the kind of current medical approach, if we take a look at this diagram over here, I'll try to make this a little bit larger for you. What we can see is that the normal treatment is to take a whole bunch of patients, you use the standard of care, so whatever is the best recommended treatment. And the idea is that what you're going to see is that some people are going to see an effect, some people are going to improve from this, some people are going to see no effect, and a small group of people are going to have adverse effects. They're going to have problems with this medication. It's not going to help them, and potentially it's going to make them a little bit worse. And in many ways, this is often the approach of current medicine, this idea that there's an ideal therapy that you should start out with. And if you go to a doctor, this is the approach that many doctors are going to be taking. This approach that, okay, the first thing we're going to use is this drug. And if this drug doesn't work for you, we're going to try something else. But in that process of trying that first drug with you and seeing if it works, what you're doing is saying, okay, I've got this general population of people and you're in that population. We're going to give you the best available treatment, and then we're going to test it. And we're going to say, are you getting better? Is there no effect? Or are you getting worse? And then based on that, we're going to modify the treatment that you're going to be getting. And that makes sense at a certain point. But what about if it's a disease that is very rapidly progressive? It's making you very sick, very weak. It's life-threatening. Do you have the time to spend a day, a week, a month, several months to test out a medication to find out, is it going to work for you? Now, the concept of personalized medicine is a little bit different. Future medicine, this personalized medicine or precision medicine, as is often talked about, is we've got that same population of individuals up here, but we have it down here. But instead of saying, okay, we're going to try you with this preferred treatment, the standard of care, the thing that we're using on most people, we're going to do a little bit of testing first. We are going to learn about your family history. We're going to learn about your medical history. We're going to run some clinical tests to find out, how fast are you going to clear the medication? Are there other things that are going on in your body? And we're also going to do the genetics, because there's, learning more and more about the genetics every day. But there's a good indication that certain people with certain combinations of genes are going to do well with the treatment. And other people with different combinations of gene information are going to do less well. But we're going to make that decision based on the culmination of all of this information that we're going to collect. And instead of doing just one treatment up here, what we're going to do is say, okay, we've got individuals up here that are going to be best treated with, whatever this green medication is. We've got another cluster of people here, they're going to be treated best with this kind of orangish medication. And we're going to have this individual down here that's going to be treated best with this bluish medication. And by doing that, we're able to customize the type of medication that an individual is taking and use that so that everybody is going to be showing the effect and everybody is improving. And we can see that in a variety of cases. If you're talking about a patient that has breast cancer, they will often biopsy the cancer, try to learn about the cells of the cancer, and they're going to use that information to determine what type of treatment to be used, because there's certain types of breast cancer that respond well to some type of medications, and there are other types of breast cancers that respond better to other types of treatment. So in the past, clinicians would base their decisions for preventive medicine on family history. So again, that basically collect a little bit of information about the individual and try to make a decision to get them going on a good, healthy lifestyle. Now, in many cases, genetics are still going to have an impact. If you've got a genetic predisposition for heart disease and high cholesterol, that is going to be something that you're going to have to deal with. That's something that is going to be present. And what you need to do is try to figure out other ways in which you can minimize those genetics. And so if you have a family history of heart disease and a tendency towards high cholesterol levels, it doesn't mean that you're destined to have those same problems going forward. You can alter your diet and go to a diet that is going to be heart healthy, that's going to have less cholesterol, at least the bad cholesterols, bad fats, bad lipids being present with it. So diet, exercise and activity, and medications that again are going to allow you to say, genetics put you at risk of this, but we're going to minimize the impact of the genetics. We can't make the genetics go away, but we can minimize the impact by doing other things to try to prevent it based on what it is that you need to be healthy. And so when we take a look at this, we can see that there are many risk factors that are a series of both non-modifiable or basically uncontrollable factors, and there are some things that can be controlled. And so if we take a look at something like type 2 diabetes, type 2 diabetes is an inability to control the level of blood sugar. So after you eat, the amount of sugar stays high within your blood and can cause lots of problems to other cells. And so some of the things that can't be modified, some of the things that are beyond your control, are like that family history of diabetes. And within that family history, often is going to be your genetics. You may have a genetic predisposition that says you are likely to get diabetes. Age. Diabetes, especially type 2 diabetes, tends to develop about 45 years of age or a little bit older. You can't, reverse the aging process, but you can do other things that potentially would minimize the aging effect. Race and ethnicity. Certain ethnic backgrounds are often going to have a higher predisposition towards diabetes. You can't change that. But again, there are things that you can change. So what you can do is take a look at some of the risk factors over here. So, okay, this is kind of the genetics. These are things you can't control, your age, your ethnicity, all of these things you can't change. But you can change your activity level. If you go from being physically inactive to, at least, walking several times a week, that is going to have a very dramatic impact about whether or not you're going to be at risk for diabetes. High body fat or body weight. So going on a diet, using that physical activity to get your body fat and body weight under control is going to lower your risk for type 2 diabetes. High blood pressure and high cholesterol. Again, both of these things are going to put you at risk for diabetes, but changing your activity level, changing your diet could potentially improve your blood pressure and your cholesterol levels. And so understanding the patient, understanding the whole patient, both the genetic predisposition, that what's within their genes, within their DNA, and other things that are impacting it, can inform a clinician, inform a doctor or whoever it is that's managing your healthcare to modify the things over here so that you can control some of these things and minimize your risks. Now, if we take a look at a patient's genetic profile, this is going to allow for kind of a customization of treatment. Especially when we're talking about prevention therapies. So it's always easier to avoid getting a disease than getting the disease and trying to, kind of cure yourself of it or at least minimize the impact of that. And so, the traditional way of doing things, often you may do a few biochemical tests, do, blood tests, do some enzymes, take a look at it. And then through the process of trial and error, we're going to start with that standard treatment, start with, a basic dosage, and we're going to test it out. Does it work? Does it not work? If it doesn't work, we're going to change the dosage, we're going to change the medication, try something else. This idea of personalized medicine is that we're going to combine those same tests, the same blood tests and enzyme tests with genetic results. And this is often referred to as pharmacogenetics. We're going to, decide the drug treatment based on the genetics of the individual. And so because of that, What we can do then is determine what is it that the patient needs. What is it that's going to work for the patient? And you start out with that as opposed to going through that process of trial and error. So for some people, the standard dose, normal dose of the standard treatment is going to work well. Some people are going to have a higher dose. Some people are going to have problems, are going to need to be on a lower dose. And some people are going to have to be on something completely different. And again, if we can understand what is involved in the development and progression of that disease and how genetics impacts on that and how we can measure it with potentially some of these biochemical tests, we can improve medical treatment. We can improve preventative treatment that can minimize the development of the disease, or at least slow the progression of the disease so a person doesn't get as sick as fast. And again, that is what we want if we're going to be treating these patients and trying to give them the best quality of care. Now, again, the example I gave a couple minutes ago is breast cancer. BRCA has a really long name, and I don't want you to worry about this, but BRCA1 is a gene for a tumor suppressor. And so this is a normal gene which is found within the body of most individuals. And what happens is when that gene is working properly, it's going to minimize the development of tumors. So it's going to suppress or minimize tumor development. In individuals that have BRCA1 mutations, they are going to have a defect in this tumor suppressor. So they're not going to have this normal mechanism which kind of minimizes tumor development. And you're going to see that these people then are going to be at a high risk for breast cancer and ovarian cancer. And so you can take a look at this. BRCA mutation carriers are going to be in the dark blue. The general population, which has the normal functioning BRCA suppressor gene, so it's going to be normally suppressing it. What we can see is breast cancer by age 50, the people that have the mutation are at much higher risk for it. Breast cancer by 70, you know, it's a huge, huge risk. So again, age is a factor. So going from 50 to 70, the general population sees an increase in breast cancer as well. But we can see that if you've got this defect, this incorrect information, so you're not getting the right tumor suppressor, you're not getting the right, you know, molecules within your body to, you know, attack the tumor before it develops, you're going to start to see the development of tumor. And this is going to be in both breast cancer and ovarian cancer. Much higher risk in those individuals that have a defect in their normal tumor suppressor, because it doesn't have that thing that would turn off or kill off tumors. The tumors are going to start to develop in patients with the BRCA1 mutations. So if we're aware of that, if we know that an individual has this BRCA mutation, you know, we may, you know, start out with an individual and test them, or more commonly what's going to happen is that, you know, you do a family history and you discover that many people in the family had a higher risk than normal for developing breast cancer. You're going to go through and work with a genetic counselor like we talked about a couple lectures ago, and you're going to see, do you have a, you know, functional BRCA gene that is going to be suppressing the tumors, or do you have a mutation? Do you have altered information that means that you can't suppress those tumors? That means that you're going to be at a much higher risk of developing cancer. And so if you have that information, what you can learn is that, you know, certain medications, tamoxifen is for treating breast cancer. This can be used to, you know, kill off the cancers very, very easily. You know, a mastectomy or oophorectomy can minimize the risk of both breast cancer, when we take a look at this, or ovarian cancer. So this is recognizing the risk and going through and having a surgery to remove the tissue at risk or remove the ovaries that were at risk for ovarian cancer with these mutations. We can also see that certain oral contraceptives, certain medications that a patient could be taking with this risk are going to minimize it as well. So again, with this information, understanding the genetics, we can go through and say, okay, you have this very high risk of developing breast cancer, 50-50, that's a flip of a coin, by age 50. You can minimize that in some ways by doing a mastectomy or having your ovaries removed. Is that something that, you know, people are going to be considering? If you can reduce your risk by 90% by doing this, is it something that you're going to want to do? Is it, you can reduce your risk by 60%. And again, this is, information from, the breast cancer sites and things like that. Talk to your doctor if you're at risk for this. I don't want to give medical information on this. But there are ways that if we understand the genetics, we can minimize the risk of developing cancers. And once a cancer is developed, we can understand what are the medications that are going to work best at treating that cancer. So now, we know that we've got information about the genetics, and we know that we can use that information to learn about, the risk of developing a disease later on and potentially take an early intervention. Take a look at the fact that we now have these direct-to-consumer at-home tests. So, the Ancestry model, 23andMe that we've talked about before. You can go and buy them over the counter at the pharmacy. You can buy them on the internet. They're getting better, but they're still not a medical grade test. The test may be unproven, invalid, or incomplete, so the results may be misleading. And if you're doing a direct-to-consumer test, you may not have access to, somebody that will help you interpret, the genetic information, the genetic counselors. So the availability of this genetic testing, the availability of this genetic information also increases the risk of genetic discrimination. And so if you have a genetic predisposition to an inherited disorder, it brings a higher risk at developing that disorder. So the example we had with breast cancer is if you have a BRCA1 mutation, it means you're at a much higher risk of getting breast cancer or ovarian cancer. And so if we find out that you have this mutation, it increases the likelihood that you're going to get sick, increases the possibility that you're going to be taking sick days, and it increases very dramatically the fact that you're probably going to have increased medical expenses. If you develop breast cancer, you want to treat it. You don't want to die from that, have it, progress and kill you. So you're going to go and you're going to see a doctor, and you may have surgery, and you may have, a drug treatment or radiation treatment. All of that stuff is expensive. If we know, or potentially if a company knows, or an insurance, the company you're working for, or an insurance company knows about that, they could say, okay, I got two people that applied. I've got one that's at risk for developing a disease that is going to be very expensive. They're going to have lots of sick days. I'm going to have to put a lot of money into my insurance plan to pay for it. Or somebody else, who is the person that's going to be hired? If we take a look at insurance companies basically collect lots of money in premiums with the hope that they're going to pay out less than what they bring in healthcare. And so the idea that the insurance companies work by enrolling lots of healthy people, they're going to pay their premiums and not use it very much so that they can afford to pay for the health coverage of some very sick people. And so basically what the insurance companies want to do is minimize their risk, minimize what they have to pay out. And so because of that, they want to kind of avoid pre-existing conditions. They want to avoid people that have a high likelihood of disability and death. And so because of that, and some of this has changed recently with the Affordable Care Act, insurance companies don't want to basically, sign up a bunch of sick people or people that are likely to get sick. They want to give insurance to healthy people that are going to pay them money, but not have a lot of expenses that are going to go along with it. If we have this genetic testing and this genetic information, we run a risk at which patients are going to be discriminated against because they're at a predisposition or a higher likelihood of developing a disease later on in their lives. Okay, so there are laws against genetic discrimination, but this remains a highly concerning area. This is an area that is kind of ripe for abuse. And so in 2008, we had the Genetic Information Non-Discrimination Act, GINA, which basically prohibits the use of genetic information for discrimination by health insurers and employers. It says that basically, if you do one of these genetic tests and you've got a predisposition for a cancer or some other type of disease, the insurance companies and your bosses can't use that information to discriminate against you. However, at this point, GINA, the Genetic Information Non-Discrimination Act, does not cover life insurance, it does not cover disability insurance, and it does not cover long-term care insurance. And so If you take a genetic test that says you're likely to die, not die, you're likely to get a disease which has a high fatality rate, it may be harder for you to get life insurance that would, pay out when you die to, support your family. It may be harder for you to get disability insurance because there's an increased likelihood that you may have to go on disability as you're being treated for your disease. Or, potentially, you may not be able to work for a long period of time as you're recovering. So you're going to need to use that long-term care insurance. At this point, those companies still could discriminate against you based on your genetic information. Now, the American Medical Association, the main kind of doctor organization within the United States, is fighting to protect against that discrimination based on genetic information. Their viewpoint is that genetic information should be kept confidential, that this is information that is your information that should be shared with your doctors in order to determine what is the appropriate care and treatment that you should be receiving. It shouldn't be released to your boss. It shouldn't be released to your insurance company. It shouldn't be released to other individuals unless you approve for that to occur. And so this is very valuable information, very sensitive information about you that could potentially be used to discriminate against you. And so because of that, the American Medical Association Board of Trustees continues to monitor and support federal legislation that kind of expand the protections of patients against using this genetic information for discrimination. Again, because if we take a look at it, we are going to continue to have these genetic tests. We're going to continue to do more and more of this genetic testing. But what do we do with that information? How do we make sure that information isn't used against the person that has that DNA? How do we ensure that a person isn't discriminated against simply because of what's within their DNA? Okay, so many states, even though the GINA, the Genetic Information Non-Discrimination Act, is a federal legislation, many states have adopted legislation to provide additional protections to prevent against genetic discrimination. And so, again, on a state-by-state basis, not nationwide at this point, but state-by-state, they've expanded areas to protect genetic privacy, employment, insurance, health insurance coverage, and research. Again, with laws in place, which will hopefully protect individuals from abuse based on an understanding about their genetic composition. Some readings associated with today's lecture. What does personalized medicine really mean? The Genetic Information Non-Discrimination Act. This is the National Human Genome Research Institute talking about that. Loopholes in the law prohibiting genetic discrimination. So this again points out, you're protected in some areas, but you're not protected everywhere. And then finally, an article down here says if you want to get life insurance, you really want to think about whether or not you want to have a genetic test and have that information, because if you have taken a test and if you have that information, in many cases, you have to disclose that information when you apply for life insurance. And again, it opens you to potential discrimination, because right now, according to GINA, the Genetic Information Non-Discrimination Act, an insurance company can say, okay, you've done a genetic test, you need to tell us about it, and we see that you're at risk for developing this disease in your 50s. Therefore, I'll give you life insurance, but I am now going to charge you more for that. If you take a look at life insurance, it asks you, are you, a heavy smoker? Because smoking has been shown to, impact health later on in life. And so if you're a smoker, you're more susceptible to disease. You're more susceptible to dying early than if you're not. And so or insurance companies will give people that smoke higher premiums than people that don't. And so if you do a genetic test that shows that you have a high likelihood of developing a genetic disorder later on in life, the insurance company, based on the current national laws, could charge you a higher premium. This is something that we really need to think about. And this is something, a huge ethical dilemma associated with the information that we're talking about here with genetics. So that finishes up today's lecture on personalized medicine. As always, if you have any questions, feel free to email me. Thank you and have a great day.